Hi everyone, welcome to the Digestive System Disorders, Chapter 17 of this week's video lecture. We are going to talk about the different disorders that you'll find in your digestive system. We'll start with the basic process of how the digestive system works. So the purpose of the digestive system is to break down the food and then absorb the food. So it will first break down that food into its different components, enzymes, proteins, fats. You have your carbohydrates will include like glucose and fructose and galactose, and then you're going to have everything that's vitamins and minerals that is in your food. All of that gets broken down and absorbed through the digestive system. Here's a quick anatomy. Lot of organs are involved in the digestive system, from the mouth all the way down to your anus. You have your mouth, your tongue, your teeth, your glands, your esophagus, and that goes down into your stomach, your diaphragm, your liver, gallbladder, pancreas, small intestine, into the large intestine. That's a little thing called the appendix here, which some of you might have appendicitis. You might have it or might not have it, because it's not physiologically, it's really not necessary to have your appendix for digestion. So they take it out when it gets inflamed. But there's a lot that goes on with your digestive system. It's a very important part of how we live. So we first talk about what our gut wall is made of mucosa, the submucosa, circular and smooth muscles, longitudinal smooth muscles, and the serosa. So in these different layers of the digestive system, you'll find your epithelial cells, your mucus producing cells, and then the area of the connective tissue will have your blood cells, your nerves, lymphatics, and secretory glands, and then your muscles that will help move the food and food products through that system. So your upper gastrointestinal tract starts with your oral cavity. So this is where your body starts to break down the food, and your mouth and the saliva that is excreted into your mouth actually has enzymes in it that will also start to break down the carbohydrates of that food. And then that food is developed into a bolus that will then go down your esophagus into your stomach area. So here's your oral cavity. Lots going on in the mouth there, with the different teeth and the tongue and the ducts and the salivary glands. So then you have your stomach is expandable sac. So it acts as a reservoir and also the breakdown of some of the food that happens initially. It has muscle layers in there so that can churn that food and mix it with the enzymes and the hydrochloric acid that helps to break down that food. There's also the production of intrinsic factor in your stomach. So this is the factor that is essential to absorb vitamin B12. So if you are lacking this intrinsic factor, then you're lacking in absorption of vitamin B12. This is also what happens. It's in the stomach. This ball of food forms what they call chyme, and that's what moves through your system and gets further broken down and absorbed or not absorbed and is removed as waste later on in your digestive tract. The liver is what we call the metabolic factory of the body. So it's very important function, and you cannot live without a liver. It receives blood from the hepatic portal vein, and this transports nutrients from your intestines to your liver. So the liver, that's how you get the necessary minerals and vitamins from your food that you ingest into the liver. So the cells in the liver also have a storage capacity. So it stores carbohydrates, protein, and it is involved in fat metabolism. In the storage of carbohydrates and protein, what it will do is it will keep it in storage until it's needed for use in other areas. The liver also is very important in our clotting. So it produces plasma proteins and clotting factors. It also breaks down old erythrocytes and produces bile. So it has a lot of functions functions and a lot of important functions. That's why the liver is so important. The pancreas has, not only does it has hormones, but it has enzymes that help to break down the food. Digestive enzymes and electrolytes include trypsin, chymotrypsin, carboxypeptidase, ribonuclease, pancreatic amylase, bicarbonate ions. So you also have a pancreatic duct that also joins the bile duct that enters the duodenum. So this is where it helps to continue to break down food and help to absorb food. And then you have your lower gastrointestinal tract that is going to that's going to start after your stomach and will be the duodenum and then the jejunum and then the ileum. This is the major site of absorption. So it's very important when you have patients who can't absorb nutrients, or they have what we call a short gut. They're missing parts of their intestine. They can't absorb the nutrients fully, so they have a problem, and they might have either vitamin or mineral deficiencies or deficiencies in nutrients because we don't have that tract, or the gastrointestinal, the small intestine, that is going to absorb these nutrients. Again, here's digestive enzymes and where they work. Nice little chart that you can look at and see. The pancreas has a lot of functions. Then you have some functions of the intestinal mucosa and the gastric cells in the stomach. And the parotid gland also is the first part of that process where it creates the salivary amylase in your mouth. The large intestine, that is what again holds your resident normal flora, so the bacteria that is normally living in your gut usually resides in your large intestine. Vitamin K is synthesized in your intestine by bacteria. This is where you have actually the fluid and electrolyte reabsorption. So in your large intestine, it will reabsorb fluids and back into your vascular system. This is also where electrolytes are reabsorbed that the body needs, and what the body doesn't need will continue out. And this is what happens in this area, is the formation of the solid feces, and this is where mass movements happen, that's peristalsis, to get things moving through your digestive tract. Neural and hormonal controls of your digestive tract include cranial nerve 10, and in this, when this is stimulated by the parasympathetic nervous system, it increases motility. That's that gurgly sound that you might hear when you have hyperactive bowel sounds. It also increases the secretions that can add to those motility. The sympathetic nervous system, on the other hand, is stimulated during times of fear and anger, and this inhibits gastrointestinal activity, basically causes vasoconstriction and blood shunting away from the stomach to other more important parts of the body, which the body considers more important: the brain, the muscles for movement. So this actually shuts down during times of your flight. So in the fight or flight type of reaction, the system is going to shut down the digestive system because of this, and going to divert the blood to other areas of the body. This is a table that you can look up in your book, and just talks about what controls the digestive system, the hormone control, and the nervous or neural control systems. Again, as we go on, so the facial nerve 7 and the glossopharyngeal nerve 9 also have a role in the digestive system. So the facial nerve, these nerves will provide a continuous flow of saliva in the mouth, and then it will increase the production during certain times. So when you have the stomach is stretched, then you will have an increase in activity in these nerves. So you'll have the peripheral nerve, parasympathetic nerve stimulation when your stomach is stretched, saying that there's food in your stomach, so it stretches and it tells them to increase the peristalsis and gastric secretions to get that food moving through your system. Normally, your stomach should empty within 2 to 6 hours after meals. So usually that's a normal time for the stomach emptying. There are problems with delayed stomach emptying, or also problems with food moving through the system too fast. So it's hormone controls. So you're going to, the gastrin, histamine, secretin, and cholecystokinin are hormonal controls that act on the stomach to either increase motility or increase hydrochloric acid, decrease secretion. So they work on the digestive system to what is needed at the time, either to increase, open up sphincters, promote emptying, or promote some kind of breakdown of the food. So digestion and absorption. So digestion actually starts in your mouth with that saliva amylase, where the carbohydrates are starting digestion in the mouth, and they continue into the small intestine. Proteins are digested in the stomach. It starts in the stomach and actually continues into the small intestine. Lipids are emulsified by the bile that comes from your gallbladder and your liver, and before they are broken down, they're emulsified, and they form what they call chylomicrons, lipids, from this breakdown and emulsification. So fat-soluble vitamins, which means that you need fats in order to absorb these vitamins, and they are A, D, E, and K, so they're best absorbed with fats. Water-soluble vitamins are vitamins B and C. They diffuse right into the blood. But in order to absorb some of the other ones, you need fats to help them absorb. Electrolytes also are absorbed by active transport or diffusion inside the digestive tract. And drugs, so when you take drugs, medications, they will be absorbed mostly in the intestines, depending on the drug and what they're working on. Some drugs are absorbed in the stomach, so if you have a patient, sometimes we have patients who have G tubes, or what we call and J tubes, the tubes that are going directly into the jejunum. You need to know where the actual medication is being absorbed so that we can make sure it gets into the right area. So you have different enzymes, different processes that happen in different parts of the digestive system. Water is absorbed by osmosis. So about 700 mLs of water is secreted into the digestive tract region. And this is what helps move the contents through your system. So you need water in order to move it through your system. We ingest about 2,300, hopefully, mLs of water a day through our food and fluids. So not only our foods that we intake, but our food that we intake does have water. So we take in about 2.3 liters. And then we only lose about 50 to 200 through our feces. Now, it's different with urine, but this is the digestive system, so we'll talk about the feces. So you're losing 50 to 200 mLs a day. So it's not a whole lot of water. But if you do have severe vomiting or diarrhea, this is going to affect greatly how much water you are losing. You will lose much more water and electrolytes if you are suffering from vomiting or diarrhea. So what do we see when we see digestive disorders? What do we look for? What kind of symptoms? Well, obviously, anorexia, meaning we don't want to eat. Nausea, upset stomach, nausea that can then turn into vomiting, which is a violent expelling of the contents of our stomach through the mouth. Also, we have bulimia. That's a disorder, mostly considered a psychological disorder, but you do have bulimia where you have the active also vomiting of the contents of your stomach. So signs and symptoms of a digestive disorder can be systemic infection. If you have an infection in your gut, that is easily transmitted to the rest of your body, and it can cause a systemic infection. The gut is considered dirty, so there's a lot of bacteria that live in your gut that if it gets into your body or leaks into your other areas of your body can cause some severe infection. Uremia, you can have emotional responses. Your digestive system is linked to your emotions, so you can have some emotional responses to digestive disorders. Motion sickness, pressure in the brain also. So if you have high pressures in the brain, that will cause you to be nauseous and vomit. Overindulgence of food and drugs, and also of pain. Pain is definitely an indication of a digestive disorder. It can be gastritis or something worse. So anorexia and vomiting will cause serious complications because you're losing you're losing the food that you've taken in, you're losing the bile that is in your stomach that helps break food down. You can become acidotic from vomiting, or alkalotic. Actually, more likely you're going to be alkalotic because you're losing that hydrochloric acid through the vomiting. Anorexia often precedes nausea and vomiting, which you don't feel like. And when your stomach is not feeling well, you don't want to eat anything because you're just feeling like you're going to throw it back up. So nausea is an unpleasant feeling. It's your body telling you that there's something wrong in your digestive tract and not to put anything in it. It's stimulated sometimes by distension. Eating too much food can make you nauseous. Irritation by either a food that you're allergic to or that you're sensitive to, or inflammation of the digestive tract also will cause nausea. Nausea can be stimulated by smells, so your olfactory system can have an effect on nausea. Visual images, again, there's like an emotional response connected with the digestive system. Pain can cause you to be nauseous. That is one of the signs of severe pain is nausea. Chemical toxins or drugs that you take can also make you nauseous. Like if you have too much of one thing, it can make you nauseous. So vomiting center is located in the medulla. We have a protection. We have an automatic need to protect our airway when we're vomiting. So we do try to protect your airway. There are some instances if you are compromised anyway, like your mental or consciousness is compromised, you do not keep that protective airway mechanism in place, and so you have a high risk of having aspiration from vomiting if you cannot protect that airway. Vomiting includes, like I said, forceful expulsion of the products in your stomach, which we call chyme, and a bile. If you get where you're vomiting cyclically or you're vomiting over and over and the only thing you have left in your stomach is going to be bile. So you have some bilious, and that looks green, yellowish green. Like I said, bulimia is an eating disorder. It damages your GI tract. It can damage your oral mucosa because of the acid from your stomach. As they're continually throwing up, that acid will break down the oral mucosa, it will break down the teeth, and also erode the esophagus. So how the vomiting center is activated, again, by distension or irritation of the digestive tract from stimuli from the brain, sights or smells, or actually from ischemia. So a lot of times you'll have patients who have cardiac diseases because they have low perfusion to their guts. They're often very nauseous and they vomit after meals a lot because they have a low perfusion to that gut, or some ischemic tendencies because of the poor perfusion. Or if you have a situation where you might have a necrotic bowel, that will also activate the vomiting center. Pain or stress, inner ear. So if we have abnormalities or in our inner ear, that can cause vomiting, or at least it can cause nausea and vomiting. Increased intracranial pressure, so increased pressure in our brains will cause nausea and vomiting as well. And of course, then we have some drugs and toxins and chemicals that will affect it. So this is a nice little diagram of what the vomiting reflex includes and how vomiting actually occurs. What I find interesting, you always, like, if you've ever had the stomach flu or eaten something that has made you sick, you're gonna have that hypersalivation. You get that, like, a lot of secretions right before you get pale, you get sweaty, your heart starts to race, and then your abdominal muscles contract forcibly. And to me, I mean, at least I feel like it's involuntarily, so to vomit, to expel whatever is causing the problem. Um, Again, here's just more of the reflex activities of actual vomiting. Characteristics of vomitus depends if you have blood in the vomit. Hematoemesis means you have blood in your vomit. Coffee ground vomit is more indicative of older bleeds, like if the blood has sat in your stomach for a long period of time, it will look coffee ground. If it's bright red, then it will indicate an active bleed in your stomach or elsewhere. Bile, so again, yellow or green, if you're throwing up yellow or green secretions, that's bile from the duodenum. Um, so if you have a deeper brown color, it means that material that is coming from the lower intestine, which is usually pretty abnormal. Um, so if you have vomiting of undigested food, that is an indication that you have a problem with gastric emptying or even an ileus, that your stomach just not moving food through your system at all. So if you're vomiting every time you eat, that is a sign that you might have either delayed gastric emptying or just completely not gastric emptying at all. Diarrhea. So the other way that we lose or can have dysfunction in our gastric is by diarrhea. It's excessive frequency of stools, loose or watery stools. That mean you're going to the bathroom more times than you should be, and it's not formed. It can happen during infection or inflammation. You have gastritis. You have the stomach flu. You have in certain cases, like certain other diseases, will cause diarrhea, like Crohn's disease or ulcerative colitis disease will have a lot of diarrhea associated with it. And prolonged diarrhea will lead to dehydration, electrolyte imbalances, acidosis, and malnutrition. So because things are moving through your system very quickly, even though normally we lose between 500 or 50 to 200 mLs of water in normal processes, in diarrhea we are going to lose a lot more water, so it leads to dehydration. And we're losing a lot of the acid as well, so we end up usually being acidotic, and then the electrolytes aren't being absorbed efficiently, or we're not able to excrete what electrolytes we don't need, so that ends up becoming imbalanced. Common types of diarrhea: small volume or large volume and small volume diarrhea. So large volume, um, again, limited reabsorption happens. Small volume can usually occur with inflammatory bowel diseases. You may have stool that has blood or mucus or pus in it with these bowel diseases, and also often accompanied by abdominal cramps. So another symptom of digestive problems is when you have what they call fatty diarrhea or aciduria, and this is not just fatty diarrhea; it could just be fatty stools as well. They're characterized by really foul odor, odor stools. Celiac diseases and patients with cystic fibrosis will have this type of diarrhea. So it's usually associated with fat digestion, and a lot of times the abdomen will be distended in these patients that have fatty diarrhea. So again, blood and stool. So blood and stool indicate that there's some bleeding going on somewhere. Frank blood is just bright red blood that comes while they're having a bowel movement. We will do an occult blood. So occult blood is when we might suspect that there is a bleed somewhere in the digestive system, but we're not sure. We don't see gross evidence of blood. So we'll do what we call a Colt test. We test a small amount of the stool to test for the presence of blood. And things that can be causing these things are like small bleeding ulcers. So maybe not large amounts of blood, but small bleeding that are bleeding consistently will show the occult blood. Melena is dark colored tarry stools, and this is indicative of bleeding in the upper digestive tract because that blood gets incorporated in that stool, and it gives it that the red from the blood, the erythrocytes will give it that really deep dark color to the stool. Gas, swallowing too much air, drinking from a straw, bacterial in food can cause gas. Alterations in motility also causes gas. Gas can causes erectation, boborygmus, abdominal distension and pain, and flaccus is what causes gas in our system. And then we have on constipation, which when on the opposite of diarrhea is we're not having enough bowel movements. It can be acute or chronic problem. Chronic constipation can cause hemorrhoids, anal fissures, or diverticulitis because usually it is because the stools become hard and they don't move through the system very well. Causes of constipation are weakness of smooth muscles, or age or illness can cause constipation. Not taking enough fiber, not taking enough fluid. They're not able to respond to the defecation reflex. These are patients that might have spinal cord injuries, patients that are immobile, also because moving, you got to move is what we say. So you got to get up and move in order for your digestive system to move and have a bowel movement. Some neurological disorders. Opiates will cause constipation as well. Antacids or iron medications and tumors and structures can cause constipation. Electrolyte imbalances we talk a lot about because of the digestive system is where they will absorb electrolytes, or they will either reabsorb or absorb electrolytes depending on what your body needs. So this is a good place to, when you have dysfunctions, to experience those electrolyte imbalances. Visceral pain. So visceral pain is that really deep pain in your intestinal system. Burning sensation can mean that there is an ulceration in your upper digestive tract. You have gastric reflux. A dull aching pain usually is indicative of the stretching of your liver capsule, so you get that dull aching pain in your abdominal area. Cramping will happen with inflammation, with distension, stretching of your intestines, so you get my cramping feeling. Colicky is kind of these spasms. A lot of babies will get colicky and they'll be very upset because their intestines are spasming as their food moves through their digestive system. Somatic pain are linked to spinal nerves. So it's the abdominal pain that is localized, that you can tell exactly where it's coming from. It usually is involved with the parietal peritoneum. And when you have what they call rebound tenderness, so when you press in and release, the patient will identify pain when that pressure is released, and so it's called rebound tenderness. Referred pain, you can get referred pain where you have pain is perceived to be in a site other from where it's coming from. So you can have referred pain depending on what the diagnosis is, depending on the nerves that are involved. So here we have different areas of referred pain where you might find it, where you're going to have the pain, or where the problem is and where you're going to have the pain. So pancreatitis, you can have referred pain up into the shoulder area. So it depends. It's kind of a way that sometimes they use it to also diagnose what the problem is if where your pain is referred to. So malnutrition. So malnutrition can be a couple different causes. Malnutrition can be a caused by genetics, so you can have a deficiency in being able to absorb certain nutrients or have enzymes that will help break down and absorb those nutrients. It can be non-organic, which means that you cannot eat enough of something so that you might have a deficiency in that vitamin. Like you can have the B12 deficiency, you can have B12 deficiency because you lack the intrinsic factor in your stomach. You can have an iron deficiency because you're not getting enough iron in your food. Malnutrition, so if you have generalized malnutrition, a lot of times they'll have anorexia, vomiting, or diarrhea. In some of causes include your inflammatory bowel disorders, cancer treatments, wasting syndromes, and again, just not having the available nutrients available, the needed nutrients available, or just not taking in enough of those nutrients. Diagnostic tests that we use for the GI system include x-rays, ultrasounds, CTs, MRIs, and then a lot of times when CTs and MRIs, we will use tracers so that we can actually visualize what's going through the digestive system. Other tests include looking at your upper GI or your lower GI. So in the upper GI, they'll go through your throat and go down into your stomach, and they'll look in your stomach and the esophagus to see if there's any problems there. And then you have the sigmoidoscopy, the colonoscopy, will go up the other direction into through your anus, into your large intestine, to your small intestine to see if they can find any issues there as well. They can check your stool. So in your stool, they can check and see if you have an infection, a bacterial infection. Parasites and ova can be living in your stool, bleeding tumors, malabsorption. So they'll check the stools for different types of suspected infections that you might have. You're also going to check, because of all of the different organs associated with the digestion, they're going to take blood tests. They're going to look at your liver function tests, your pancreatic function tests. They're going to look at any cancer markers that you might have. So those blood tests will tell them if there's a problem with one of those organs. Therapies, depending on what the disease is, it can be a dietary modification. So like in celiac disease, we're going to tell them to be gluten-free. We're also going to tell people to reduce or moderate their intake of alcohol and coffee because that can be very irritating to the stomach and that can cause ulcers. Or actually, it can irritate ulcers that are already there. Increase your fiber and fluid intake. Reduce your stress if you can. Because in times of stress, you will get like in severe cases of trauma, they can get stress ulcers from that trauma. And also there are drugs that can help to treat some of these problems of digestion, especially the GERD. There's a lot of drugs that can help with that, proton pump inhibitors or some kind of inhibitors for the acid that's produced in the stomach, or buffers for that acid in the stomach that will help. Antacids, like we said, antacids, antiemetics. The most common antiemetic you're going to find is called Zofran. So that is one common antiemetic that they give people who are having nausea and vomiting, maybe post-operatively. If you have constipation, laxative and enemas will be used to help treat that constipation. And the other hand, you have antidiarrheals that will work on reducing your peristalsis or relieving your cramps, because when you have diarrhea, your stomach is cramping as that fluid and food moves through your system very, very quickly. Other drugs, sulfasalazine, anti-inflammatory and antibacterial, clarithromycin or azithromycin is also something that will treat what we call an H. pylori infection. That is a bacterial infection of your stomach that will also create increased secretions and like a GERD type of condition. Sucralfate coats your stomach, so it gives a barrier to the irritants in your stomach, such as NSAIDs. So they might use sucralfate. Anticholinergic drugs will reduce your parasympathetic activity, which we said will increase the secretions in your stomach and will slow down the secretions and slow down the motility. Histamine 2 antagonists are also used for GERD, and so our proton pump inhibitors are used for GERD as well. All right, so continuing on, here's a nice little table that you can refer to in your book that will, or if you know people that have stomach issues, that might help them. So it's actually very good reference. So let's start with talking about upper gastrointestinal tract disorders, so upper GI. What disorders happen in the upper GI? So first we'll talk about, of course, the very first part of your upper GI is your oral cavity. At birth, they can have what they call cleft lip and cleft palate, where the cleft lip, where there's a split and that lip doesn't fully form in utero. Also the palate, the soft palate in the mouth might have a cleft in it, either a partial or complete opening. This usually happens in the 6th or 7th week of gestation. There's no real predictors. They're not sure exactly why this happens. And when the baby is born, they have not a lot of issues, but they need to use special bottles and for feeding them and take special precautions so that they don't get otitis media or they don't have any aspiration. And then when they're old enough, they will get a surgical repair done, and they will be referred to a speech pathologist or orthodontist to help them to learn how to speak in case they have impediments from their surgical repairs and orthodontics, because they might have problems with their teeth after the surgical repair. So you might get ulcers in the mouth, and this could be caused by some of your resident flora. Lesions in your mouth can happen on the movable mucosa, the buccal mucosa, the floor of the mouth, or the soft palate. And these will sometimes heal spontaneously, like you have a little ulcer inside your mouth that you can feel, and that might be a little bit irritating for a while, but they tend to heal pretty quickly. Candidiasis is a fungal infection of your mouth. Also, it is an opportunist infection, so it lives in your mouth. Candida albicans is something that is kind of there in your mouth always, but it will cause problems when it has an opportunity. We call oral candidiasis thrush. So that is basically on the tongue, you will see a white kind of patchiness on the tongue. And a lot of times this is from people who are taking antibiotics, because antibiotics kind of kill all the bacteria. And so it kills that bacteria that holds the fungus back. So it kind of, but when that bacteria is gone, the fungus just thrives and will replicate and cause problems and will look like thrush. This happens with a lot of immune-compromised individuals. Diabetes is also prone to thrush. So like I said, it looks like a white patch on your tongue that doesn't go away. You can't really brush it off. It's just this white patch on your tongue. That's thrush. So this is just a picture of the organism that causes thrush. Herpes. So herpes simplex infection is transmitted by kissing or close contact. So it will cause an outbreak, but then it will live dormant in the sensory gangland. So it's always there, ready to pop up again in times of stress or immune compromise or as you get older. So it doesn't go away. So you'll always have it. You can use antiviral medication, can help if you can quit. Like some people say that they can kind of feel it coming on, so they start taking their antiviral medication, and then it will heal quickly or prevent the actual eruption of the blisters. Syphilis is another infection that you can see. This is not limited to the mouth, but it can have an effect on the mouth, cause oral lesions. It's highly contagious during the first and second stages. In the primary stage, you'll see what they call a chancre. It's a painless ulcer on the lip or tongue or the palate. It will heal spontaneously. In the secondary stage, it can be highly infectious. So this is a stage that you don't want to be around people, or you want to make sure that if you know someone or someone you know has it, that they're not spreading it. This will also heal spontaneously, but you can treat either stage or both stages with long-acting penicillin to get rid of it or to treat it. Caries, so these are your cavities in your mouth. They are caused by different microbes or bacteria. And the bacteria will break down sugars and produce large quantities of lactic acid, which will then dissolve the tooth enamel and cause tooth erosion. And then you can get the cavities where it can communicate with the nerve, and if it affects the nerve, then you have to have a root canal. That's why it's important to brush your teeth, or even after you have something sugary, that you make sure you either rinse your mouth or brush your teeth. Anti-cavities or anti-carie treatment is using fluoride, fluoride toothpaste, those kind of things. That's why we have fluoride toothpaste. Gingivitis is when your gums are sensitive. They can be swollen, red, bleed easily. They can be a result of bad hygiene, oral hygiene, a result of accumulated plaque in your mouth. That's why you have to go get your teeth cleaned at least once every 6 months so that that plaque doesn't accumulate and cause gum disease. Also, excessive or improper brushing can cause gingivitis. So just be careful and make sure you see your dentist on a regular basis and brush really well. Periodontal disease is another thing that you have to is another disease of the oral cavity. You can have damage to the periodontal ligament in the bone, and it's predisposing. So if you have gingivitis, it predisposes you to periodontal disease. So it's caused by microorganisms. That is a result of bad dental hygiene. You can lose teeth depending on the severity of the periodontal disease. You can lose your teeth because of it. So this is a sign. This is healthy. This is a sign of healthy periodontium. And let's see a sign of disease. So you can see the kind of the black, the buildup of all the plaque that is running the gums and the teeth. So it may result in losing teeth or weakening teeth. Hyperkeratosis or leukoplakia is also white plaque, evidenced by white plaque, epidermal thickening of the mucosa. It can occur in the buccal mucosa, so the buccal mucosa here, the palate, which is that, or the lower lip, may have problems and may be related to smoking or chronic irritation. I would assume that would be like chewing tobacco would cause that. They require monitoring because they can turn into cancer. So make sure that if the dentist or someone identifies that you do have this leukoplakia, that it is followed up on a regular basis. So cancers of the mouth. So squamous cell carcinoma is the most common cancer. People who are at risk are people who are smokers, alcohol abuse. They have leukoplakia. Usually happens in the floor of the mouth or the borders of the tongue. You usually see multiple lesions. So people who are suffering from AIDS will have Kaposi sarcoma as common cancer of the mouth. And then lip cancer, common in smokers or pipe smokers. And this has a better prognosis, usually found a lot earlier so that it can be treated a lot earlier. So this is a picture of the squamous cell carcinoma on the forehead. So then you have salivary gland disorders, sialadenitis, mumps, infectious parotitis, and non-infectious parotitis. Those are disorders of your salivary glands and your oral cavity. Dysphagia, difficulty swallowing, can be caused by a couple different reasons. A lot of times it's neurological deficits. Stroke victims tend to have can have dysphagia. A muscular disorder, so if you have a muscular disorder of your, like a generalized muscular disorder of your entire body, you may not be able to swallow very effectively. If you have some kind of mechanical obstruction, if you have a large tongue, or if you have a cancer or something that is blocking your airway or your esophagus, you can have dysphagia. So they can present with pain when they swallow. They can present with the inability to swallow larger pieces of solid material, so larger pieces of food, and they also have difficulty swallowing liquids. So when they swallow liquids, they tend to cough or have some gurglingness or get hoarse after they swallow liquids. So those are all signs of dysphagia. Again, neurological deficit can include infection, stroke, brain damage, or a lack of nerve response. So your esophageal sphincter relaxes or does not relax because it doesn't have the innervation, doesn't have the nerves. It's lacking the nerves. So muscular disorder, again, muscular dystrophy will cause dysphagia and inability because of the muscles, weakness to actually swallow effectively. Mechanical obstructions, congenital atresia, meaning that you're born with the smaller or narrowed esophagus, or they are what they call, they have a transesophageal fistula where the actual esophagus just doesn't connect when they're born, so that can actually also happen. Stenosis of the esophagus, that could be a mechanical obstruction, so a lot of times when you have constant irritation of the lower esophagus, it can develop scar tissue that can also create a mechanical obstruction. Esophageal diverticula, which means that you have outpouchings of the esophageal wall. They're kind of like, creates a form like an aneurysm type thing where they have pouches where things can kind of get diverted to. Sometimes it happens when they're born with it, and sometimes it follows an inflammation. Irritation, inflammation, and scar tissue, like I said, can cause the mechanical obstruction. Signs of dysphagia can include foul breath, chronic cough, or hoarseness. Tumors, you can have a tumor on your throat that can, or anywhere in your throat area, that can be internal or external, that can cause a mechanical obstruction as well. So this is just a couple examples of mechanical obstructions. You have the fibrosis or scar tissue here that usually happens because of long-term GERD, a tumor that pushes on your esophagus, or you have the outpouchings in your esophagus where food gets diverted to and causes these obstructions in your throat. So another cause of dysphagia, like I talked about, congenital, where these tubes don't connect. Or there is an abnormal connection from the esophagus to the trachea, neurological damage, or you're losing peristalsis, means that your food, you're losing that ability to push food into your stomach, and so it just creates this pouch, and they collect in this pouch. Esophageal cancers, squamous cell carcinoma, usually found in the distal esophagus. Poor prognosis if you find it later on, so early diagnosis is key to good outcomes. Associated with chronic esophagitis, which means GERD, achalasia, hiatal hernia as well, can be associated with chronic irritation and alcohol abuse or smoking. So hiatal hernia, what is that? Basically, this is when part of the stomach protrudes through the thoracic cavity. So we can have a sliding hernia, which means it goes in and out. It doesn't stay in the same spots, or rolling or a paraesophageal hernia. So part of the fundus of the stomach can move through a weak part of the hiatus in the diaphragm, and that becomes trapped. It doesn't come back out, so that can cause issues as well. Here's a good example of your sliding hiatal hernia. This is your esophagus, and as you can see, it's putting pressure on that esophagus here. And this is where you have a sac because of the hernia has pushed through the diaphragm. This is your diaphragm here. That's a hiatus. That little corner here is our hiatus. So there's a pouch that pushes through there, and that causes constant irritation on your esophagus. Heartburn or paresis, frequent belching is a sign of hiatal hernia. Increased comfort when you're laying down. Substernal pain that radiates to your jaw or shoulder is also a sign. So GERD. So we've been talking about GERD, which is the reflux of gastric contents into the distal esophagus that does cause erosion and inflammation. It is often seen with the hiatal hernia, but also can be seen with H. pylori. Delayed gastric emptying can be a factor as well. It can cause a buildup of the gastric contents to be pushed back up into the esophagus. We tell patients who are suffering from GERD to avoid caffeine, fatty and spicy foods, and that includes a lot of times fried foods, to avoid the fried foods, alcohol, smoking, certain drugs, and then we usually give them medications that can help reduce the inflammation and prevent reflux. Proton pump inhibitors, H2 antagonists, antacids. So those are the types of medication that we use for these patients. Acute gastritis is when your gastric mucosa is inflamed. This can happen for many different reasons. Allergies to foods, spicy foods, alcohol intake. NSAIDs is a big culprit. So overingestion of aspirin and NSAIDs can cause gastric bleeding. So it's very important that you know, or if you know someone who takes a lot of like ibuprofen or Motrin or those NSAIDs, that they can cause gastric ulcers or bleeding ulcers. Radiation and chemotherapy are also causes of acute gastritis. Signs of gastrointestinal irritation, anorexia, nausea, vomiting may develop, throwing up blood, epigastric pain, general discomfort, and then you can get an infection or diarrhea might develop from acute gastritis. It's usually self-limiting. Your gastric mucosa will usually regenerate and you'll have no problems. But you might need, if you're prolonged vomiting, then of course you're going to become dehydrated and you're going to need some supportive treatment. If it's because of some kind of bacterial infection, then we may treat it with antimicrobials. Chronic gastritis, so people who have a chronic infection, sometimes it's because their stomach mucosa has atrophied and they lose their secretory glands. They also have a reduced production of their intrinsic factor. H. pylori can be a cause of this, and that is often present in chronic gastritis. So they do a test to test for this bacteria specifically. Signs may be pretty vague, can be signs of many diseases like a mild epigastric discomfort, not wanting to eat, not having intolerance for certain foods. So if you do have chronic gastritis, you are at risk for peptic ulcers and gastric cancers. So, and certain autoimmune disorders are also associated with gastric atrophy, so that's important to know too. So gastroenteritis is when your inflammation of the stomach and intestines is caused by usually an infection, but it can also be caused by allergic reaction to foods and drugs. So you may eat food that is contaminated with food, soil, and water, fecal from other animals. Usually it's self-limiting. It rarely results in a serious illness, but it can. You can have epidemic outbreaks. Some food, if you see some food that is recalled, like lettuce is a very common food that you might find bacteria on, that can cause this kind of gastroenteritis. This is a table that you can look at in your book of the different pathogens that can cause, that is transmitted by food and water. So Some E. coli lives in our intestines. It's one of the natural flora, but there are some strains that can cause disease, and these are infective strains that you can find. So they will do a test and look for these different strains of E. coli, but in general, E. coli lives in your intestines without causing any kind of disease. Um, Gastric and duodenal ulcers, again, most likely caused by H. pylori. H. pylori can wreak pretty good havoc on your stomach if you have it. It will break down the mucosal barrier, and sometimes it will break through the barrier to the point where it bleeds. So increased acid secretion can lead to ulcers. So if you have, a lot of times, if you have prolonged or chronic GERD, this can lead to gastric ulcers. These are different locations you can find different ulcers. They are named by the location that they are found in. So things that can cause the ulcers are inadequate blood supply, excessive steroid secretion, that's an intrinsic, or you can have extrinsic factors like steroid medication. Can also cause ulcers. Steroids are very difficult on the stomach, so you have to tell the people, or you got to make sure that you take food with any kind of steroids. Aspirins, NSAIDs, and alcohol break down that mucosal layer, and then you have atrophy of your gastric mucosa, which leads to chronic gastritis. So increased pepsin secretions. So what happens when you have the gastric and duodenal ulcers? You also have rapid gastric emptying, which means that things move through your system very quickly and then don't get absorbed. Complications of peptic ulcers are hemorrhages and perforation, so they can bleed, or they can actually perforate your stomach and go through the entire gastric wall. And then that chyme will enter the peritoneal cavity, and you can get chemical peritonitis because that chyme has other things in it that will cause inflammation of the peritoneum. And then it can cause an obstruction that because of the scar tissue. Once the gastric or duodenal ulcer is healed, the epithelial tissue may be replaced with scar tissue, which may then cause a mechanical obstruction. Like if it's in the duodenum and you have a scar tissue there, it's not a very big space, so that can cause a mechanical obstruction. Signs and symptoms of ulcers: epigastric burning. Tests will include an endoscopy or barium X-ray, and endoscopic study or biopsy will diagnose. And then, of course, if you have the H. pylori bacteria, they will treat with antimicrobials along with proton pump inhibitors until the bacteria is gone. And then we also will tell you to cut out anything that exacerbates the ulcers: alcohol, fatty foods, fried foods, spicy foods. So those kind of things that will exacerbate the ulcers. We tell people to stop eating those. Stress ulcers can be associated with burns or severe trauma, hemorrhage or sepsis. They happen very fast, within hours of the event usually, and usually you can see hemorrhage or severe pain as an indication that they have a stress ulcer. This is just a picture of multiple stress ulcers. You can see all these black little dots here are the stress ulcers from somebody's stomach. Gastric cancer. Diet could be a factor. Smoked foods, nitrates, nitrites. So look at your food. What is your food additives? Make sure that you reduce the amount of nitrates and nitrites in your food. Symptoms are usually vague, so what happens is it's usually too late by the time they find the cancer. They're usually in a later stage and it's difficult to treat, so there's not a great prognosis for people who get stomach cancer. Their survival rate is about 20%. Dumping syndrome. Dumping syndrome is basically when you completely get rid of everything in your gastric, in your duodenum, without digestion. So basically, whatever's in your duodenum, it just dumps out of your intestinal system, and that's what we call dumping syndrome. It can happen after gastric resection or gastric bypass surgeries. So what happens is that chyme draws fluid from your vascular compartment into your intestine. With the intestine, it distends with this extra fluid. Then it stimulates increased motility. What happens a lot of times, you get a vagal response from this increased motility and intestinal distension, and you can get a sudden drop in blood pressure, get anxiety, and faint or syncope, fainting. So a vagal response and faint. It usually occurs right after meals. So what happens is when that chyme is in the system, it will stimulate the pancreas and the liver to secrete insulin. That insulin is secreted, but that chyme is dumped, so you lose that. You lose the sugar or the carbohydrates in that chyme, and then you have a sudden drop in your blood glucose because you don't have the food that your body thought it had for the increased sugar in your blood, and so you have all this insulin in your blood but not enough sugar, and so your blood glucose drops drastically. Dietary changes are usually what is used to treat dumping syndrome. Frequent small meals, meals that are high in protein, low and simple carbs. So simple carbs are easier and faster to digest. So you have low simple carbs, more complex carbs, and hopefully it will resolve over time. This is a nice diagram that you can see in your book about what dumping syndrome and the steps and how it happens. Pyloric stenosis is a narrowing of or obstruction of the pyloric sphincter. This usually happens to babies. It usually peaks at 12 weeks of birth, I believe. So it will happen in the first few months. It usually starts at 6 weeks. 6 to 8 weeks, you'll see projectile vomiting. You might palpate a firm mass in the stomach, on the right side of the stomach. The baby doesn't gain any weight, shows signs of dehydration, is always hungry because as soon as you feed them, they will have these what they call projectile vomiting, not just a spit up, but vomiting like across the room. Surgery is required to remove the obstruction and open up that pyloric sphincter. It's a very simple, easy surgery that basically has few complications. Occasionally, it may be required later in life if you have persistent feelings of fullness or increased incidence of vomiting. You might have like an obstruction in your sphincter that they need to go in and take care of. All right, disorders of the liver and the pancreas. So, disorders of the liver and the pancreas. Let's talk about. So, we'll start with the gallbladder disorder. So, you have gallstones. These form as solid material that form in the bile called calculi. That is the lithiasis, cholelithiasis. Then you have cholecystitis, which is the inflammation. So remember, cystitis means inflammation, so inflammation of the gallbladder or the cystic dust. Cholangitis is inflammation or infection of the bile ducts. And choledocholithiasis is obstruction of the biliary ducts by gallstones. So you have gallstones that are obstructing the biliary ducts. So this is a picture, a nice little diagram. You have your liver, and then you have your hepatic duct. So that's the hepatic means coming from the liver, and your cystic duct, your gallbladder is here storing the bile. And some of it goes directly into the duodenum from the common bile duct, because the common bile duct not only takes bile from the hepatic duct, but also the cystic duct and the gallbladder. And then you have the pancreas that also has a duct in it. So this common bile duct will take secretions from the liver, the gallbladder, and the pancreas and put it into the duodenum. So the gallbladder is actually just storing bile from the stored made in the liver, but it's a storage, and some of that goes directly into the intestine as well. So disorders, gallstones can vary in shapes and size. They can be cholesterol, or they can have calcium salts in them. They can be small or large stones, depending on how mild or severe the disease is. What are risk factors? Women are twice as likely to develop these stones. There's high cholesterol and bile. If you have high cholesterol intake, can put you at risk for gallstones. Obesity, multiparity, meaning you have like twins, triplets, multiparity, if you have more than one birth fetal. So oral contraceptives or estrogen supplements also put you at risk. Hemolytic anemia, alcoholic cirrhosis, and biliary tract infection puts you at risk for gallstones. Obstruction of the of the duct can result in severe pain, a lot of radiating pain, nausea and vomiting. You can get jaundice because bile backs up in the liver. You can have a rupture of your gallbladder if these continue to obstruct your continue to cause obstruction. Pain decreases as the stone moves into the duodenum. So if you're lucky enough to have a gallstone that can actually get passed into the duodenum, that pain will decrease or go away. You may have surgery if necessary. Your gallbladder may be removed by laparoscopic surgery, or cholecystectomy is what that is called. And then you might be put on a low-fat diet following surgery if they find that is necessary. Jaundice, so there's different types of jaundice, but jaundice is basically, the manifestation of jaundice is yellow skin. So it is an excessive prehepatic jaundice caused by excessive destruction of red blood cells. Usually this is caused by transfusion reactions. Intrahepatic jaundice, which is jaundice created by the liver. It occurs when you have disease or damage to the liver cells or hepatocytes. This is common in hepatitis or cirrhosis. Or then you can have post-hepatic jaundice, which is caused by an obstruction of the gallbladder, which can be obstruction by tumor or obstruction by gallstones. So post-hepatic jaundice is caused by the obstruction of the gallbladder or the ducts. There's different types of jaundice. Bilirubin measured in jaundice. So what we do is when you use patients jaundice, we do blood tests and we test their direct or conjugated bilirubin. We also test their total bilirubin, how much is measured in the blood. And then we have indirect or unconjugated bilirubin is a formula of the total bilirubin minus the direct bilirubin. So this is what tells us how bad jaundice is or what might be causing the jaundice by these tests. So the type of jaundice, again, or the blood test will tell us what type of jaundice you have, and also the changes in stools can also be indicating what type of jaundice you have. So this is just a nice cross section of the liver and ducts. Hepatitis. So basically anything that I said, of course, hepatitis is inflammation. It's inflammation of the liver. It can be caused by a fatty liver, which you can see in alcoholism. Idiopathically, it can just happen without known cause. So we do have a lot of idiopathic hepatitis or idiopathic liver disease where we don't know what the cause is. It's just affecting liver. Viral hepatitis is also can happen from contracting a virus, and it can turn into viral hepatitis. Infections elsewhere in the body can also create hepatitis. So mononucleosis or amoebiasis, like a parasitic disease, can cause hepatitis. Chemical or drug toxicity as well. So a very common drug toxicity that you might see is the toxicity of acetaminophen. Is very toxic in high doses to the liver, and that can cause liver disease or hepatitis or liver failure. So you have viral hepatitis, which is basically it's the virus that is creating damage and necrosis of the liver. It's variable, and the disease is variable. It can be very mild to very severe. The liver becomes very swollen and tender. The causative viruses are hepatitis A, B, C, D, and E viruses. It's pretty self-explanatory. Like, they didn't get very creative when naming these viruses. Hepatitis A is a small RNA virus, usually gotten from contaminated water or shellfish. Also, sexual transmission can cause transmission. It's usually self-limiting and acute. Does not usually have a chronic state. You can get vaccines if you are going to be traveling, or if you're a food care worker or healthcare worker. They offer hepatitis A vaccines. Hepatitis B, so most of people who have the HIV virus also have the hepatitis B virus. It can result in chronic inflammation, and transmission is primarily by infected blood, but it can also be transmitted through sexual contact. Tattooing or body piercing put you at risk for the virus. There is a vaccine available, and then most routinely given to children. Hepatitis C is most commonly transmitted through blood. May also exist in a carrier state. 50% of the patients that are infected with hepatitis C are in a chronic state of hepatitis. It also puts them at risk of liver cancer. We treat it with interferon injections. Hepatitis D, Delta virus. It's increased severity of transmitted by the blood. You don't see this as often. And then you have hepatitis E, which is transmitted through the oral fecal route. It does not have a chronic or carrier state, so it's acute and self-limiting. So this is just a illustration of a hepatitis B infection. Of course, we're going to continue with viral hepatitis, supportive measures, resting, diet high in protein, low in fats, carbohydrates, and vitamins. So you can use also interferon, which will decrease your viral replication, but it's not very effective. A lot of times you'll have a drug combination, an antiviral and interferon in combination that will be more effective than just one. So toxic or non-viral hepatitis, the most common one you'll see is from overdose of acetaminophen, but also from other medications. It can result from a sudden acute large dose of a certain medication, or a long-term exposure and long-term ingestion. Cirrhosis is a progressive destruction of the liver, most commonly seen in alcoholic liver disease. Also biliary cirrhosis, post-necrotic cirrhosis, and metabolic. So there's a couple different causes of cirrhosis. Basically, it's pretty much the degeneration of the liver. It can, with the degeneration and the destruction of the liver, you can get fibrosis of the liver, and then that will cause dysfunction of the liver. So the liver can't function the way it's supposed to be functioning. Bile may get backed up. You may lose loss of function. You may not know that you have this disease until it is very advanced, because your liver is very good at compensating. We will diagnose it by liver biopsy and blood tests. Initial stages of alcoholic liver disease is a fatty liver. It means that liver is getting enlarged. At this point in time, if you do catch it, it can be reversible with reduced alcohol intake. Then you get alcoholic hepatitis. and where you find inflammation and cell necrosis. This is where you can have fibrous tissue formation. This becomes irreversible. Once you get the fibrous tissue, you can't reverse the damage that has been done. And then the final stage, or we call end stage cirrhosis, your fibrotic tissue replaces the normal tissue, and then your liver does not function like it should. So functional losses, we can't remove removal and conjugation of bilirubin. We don't produce enough bile, impaired digestion and absorption of nutrients. Blood clotting factors are reduced, so we have a higher risk of bleeding. We have impaired glucose and glucogen metabolism, which can lead to diabetes. And then impaired conversion of ammonia to urea, so we can have a buildup of ammonia, which causes CNS changes or changes in mentation. Important thing to note on the functional losses with cirrhosis is that drugs that are metabolized in the liver need to be dosed differently because they will build up in the liver and create toxicity. So make sure that if you do have liver disease that they are using liver dosaging, which means that they are taking into account the fact that the liver does not work properly and that drugs can build up in that system and not work effectively. Other functional losses, so they're not storing iron or vitamin B12. So a complication, it can include esophageal varices. So they have, what happens is the blood vessels will, from the liver, will grow collaterals, and those collaterals will be found kind of surrounding the esophagus and into the esophagus, and if they become enlarged enough, they could cause a hemorrhage, and then you can hemorrhage into your throat blood. So large amounts of blood can be lost in that hemorrhage. Also, the development of ascites. So people that have liver disease often have these big bellies, and we call it ascites because their liver is not working. You're losing albumin and fluids into the peritoneal cavity. So that creates distension and pressure, and these like really big bellies. Can have very like thin arms and legs, but then these big bellies will be ascites. So here's esophageal varices. As you can see them, they create these other with the veins along the esophagus, and they have bulging esophageal varices. These are what's going to burst and cause problems and cause hemorrhaging into your throat. Here's another just example of, I'll let you look at it in your book, of a liver damage and ascites and what that looks like. Cirrhosis. Again, cirrhosis, the initial manifestations are mild and vague, meaning you don't know, and they look like a lot of symptoms from other diseases: fatigue, anorexia, weight loss, anemia, diarrhea. These are symptoms that you might see in many, many other diseases. But they also might have a dull aching pain that's present in their right upper abdominal quadrant. So that could be a sign of cirrhosis. They get ascites or peripheral edema, so they have edema in their legs. Increased bruising because of the inability to clot. You might see more bruises, esophageal varices, which you can't see, but if they do hemorrhage, then you will know because they will have blood in their throats. Then jaundice because the bilirubin that's not broken down, and encephalopathy because you aren't able to convert ammonia to urea, so that ammonia builds up, and when it builds up enough, it will cause encephalopathic changes and affect your brain. So here's just different areas that you can see the effects of cirrhosis. Treatment of cirrhosis, basically stop drinking alcohol or taking away whatever's causing the cirrhosis. Supportive and symptomatic treatment, dietary restrictions, low-fat diets, balancing your serum electrolytes, doing a paracentesis. So if they have ascites with a lot of fluid in their peritoneum, they can take a needle and pull out all that fluid to relieve pressure on their lungs or pressure on their other organs. So antibiotics can also be used. Treat esophageal varices if they rupture. Usually they tamponade them. Um, and then treatment can include a liver transplantation. So here's just some more manifestations of liver disease. Liver cancer, so cancer of the liver, usually there's a primary tumor of the liver, more common in cirrhotic liver. So if you have cirrhosis, you have a higher risk of getting liver cancer as well. Also, you have a risk of um, the liver is a site for metastatic cancer, so cancers that originate in other parts of the body. So it's easy for it to move into the liver because of the hepatic veins. Again, initial signs are usually mild in general, and they're very nonspecific. Diagnosis is done by a liver biopsy. And then if you do have liver cancer, chemotherapy, lobectomy, radiofrequency ablation can be used to treat liver cancer. Here's just acute pancreatitis, so that is inflammation of your pancreas. It results in basically your body digesting the tissue. It can be acute or chronic, or it can be acute and chronic with flare-ups. So the pancreas doesn't have a fibrous capsule, so the enzymes from the pancreas can leak out into the surrounding tissues, and this causes a lot of pain. So the substances that are released into the surrounding area can cause a lot of inflammation, can cause hypovolemia, very fast hypovolemia and circulatory collapse. So it's very dangerous. Causes of acute pancreatitis include gallstones, alcohol abuse. Sudden onset may happen after a very large meal or large amounts of alcohol taken in. Signs and symptoms of acute pancreatitis include severe epigastric pain, pain radiating to the back can be the primary symptoms, hypovolemia, shock can be a sign or symptom, low-grade fever, abdominal distension or paralytic ileus can also be a sign of acute pancreatitis. Diagnostic tests, you can do blood tests. You're going to see what the serum amylase levels, serum lipase levels are, what the pancreatic enzyme levels are, amylase, lipase, hypocalcemia, so they can see hypocalcemia and a high white cell count. Treatment, we basically make them NPO, which means they stop having them eat or drink anything. We give them hydration and nutrients through their IVs. We treat their shock and we treat electrolyte imbalances, and then we give them analgesics for their pain because it is very painful. Here's a pathophysiology you can look at in your book. Risk factors of pancreatic cancer include smoking, having pancreatitis in the past, and dietary factors. Most common pancreatic cancer is adenocarcinoma. It arises from the epithelial cells in the ducts. You will see weight loss and jaundice as early manifestations. Again, pancreatic cancer is very, very difficult to diagnose, and most often is diagnosed in its late stages, which means it has a very bad prognosis. Mortality rate is at 95%. It's not very good. So it's important to kind of pay attention to some signs and symptoms, reduce those risk factors, but again, it's not a very good prognosis. Okay, now we're going to talk about lower gastrointestinal tract disorders. Let's see what we have going on here. Celiac disease. It is a malabsorption syndrome. Not necessarily a primarily childhood disorder. It can be, but it also occurs in adults in middle age. It appears to be a genetic link, but they really can't say for sure what the cause is. It's a defect in the intestinal enzyme. Basically, it creates a toxic effect and malabsorption and malnutrition as a result. But a lot of times these people will have feelings of being bloated and just not feeling good, and sometimes it will have diarrhea or just nausea when they eat. There's a lot of different symptoms associated with it, but again, it can start in childhood, but you can also get it in middle adulthood. So first signs of the celiac disease will occur about 46 months of age. Manifestations will include fatty stools, muscle wasting, failure to gain weight, irritability, and just common or just fatigue and malaise. So how does that look like in an infant? It means that they're just not very vigorous. They're very lethargic. So diagnosed by blood tests, and basically the treatment for this disease is gluten-free. Um, any type of gluten can send them into kind of a sort of acute attack where they're just feeling awful and having diarrhea until that gluten gets out of their system. Other diseases include chronic inflammatory bowel disease or Crohn's disease or ulcerative colitis disease. These are diseases of the bowel. They cause a lot of inflammation. They may have some genetic factors appear to be involved. Like I said, they can't for certain say that, but if you have family members that have these diseases or know some close relative, you are more likely to have the disease than not, or to get the disease. Crohn's disease happens a lot in adolescents, but we are seeing it in younger kids as well. So ulcerative colitis tends to happen in your 20s and 30s. There are some similarities, and there are actually some similarities in treatment for both Crohn's disease and ulcerative colitis. It seems to be a autoimmune type disease where the immune system kind of creates this problem of having inflammatory bowels. So, oops, Crohn's disease. The small intestine is involved, and you see on biopsy when they go in there and they look at it with a scope. They'll scope the intestine. They'll see skip lesions, and so when they should see normal tissue, they'll see these lesions of it or see inflammation. They'll see signs of wall, abdominal wall destruction or fibrosis. See maybe possibly some bleeding. So Crohn's disease is diagnosed through biopsies. It interferes with digestion and absorption. So these patients usually present with a lot of weight loss or failure to thrive, chronic constant stools, bloody stools, some possibly fatty stools. They look like they're malnourished. They have a hard time gaining weight. We use a lot of what we call biologics for this disease. Remicade is one of those. Also, steroids is sometimes something that we can use to help treat this. There's just a nice little diagram that you can see in the book of what Crohn's disease looks like. Ulcerative colitis, inflammation that starts in your rectum, so it starts a little bit lower than what Crohn's is. It progresses to the colon. Tissue destruction interferes with absorption of fluids and electrolytes in that colon. A toxic megacolon can develop, which is just a very inflamed colon, and food gets trapped there and doesn't pass very easily, or sometimes they can have diarrhea, up to 12 stools per day that contain blood and mucus. Very painful because they can have very painful abdominal cramping associated with ulcerative colitis. This is what it looks like when they're doing a biopsy or when they're looking at it through a scope. Treatment of irritable bowel disease can include anti-inflammatory medications, steroids, anti-motility agents to slow down the motility, supplements, nutritional supplements, antimicrobials, immunotherapeutic agents, which is what I said, they are like the biologic agents that they use. There's several different ones these days. And then if they really have necrotic or a tissue that is non-viable, they will go in and do a resection and sometimes create an ileostomy or colostomy, which is a diversion of the intestines to the stomach area if the rest of the intestine is not functional. So this is a way that you can still eliminate, but bypass the lower part of your intestine. So types of irritable bowel syndrome include abnormal motility and secretion, visceral hypersensitivity, post-infectious, so after an infection, overgrowth of your normal flora, which can be created after antibiotics, allergy or food allergy and intolerance, and sometimes psychosocial factors. Our emotional state has a lot to do with how our stomach behaves, and so if we have some very, very strong emotions, then we might have some irritable bowel syndrome associated with that. Manifestations: lower abdominal pain, diarrhea, constipation. Sometimes they alternate between constipation, diarrhea, not very comfortable. Bloating and nausea is also associated with this. Diagnosis is based on they test for bacterial, parasites, food allergies. They do a biopsy diagnosis sometimes, and there's no real single cure for IBS. Appendicitis is the inflammation of your appendix by a fecal lift, gallstone, or other foreign material. It can be either appendicitis or perforated appendicitis. So perforated appendicitis means that appendicitis has burst and that there is bacteria and fecal or matter, whatever is trapped in that appendix has gotten into the abdominal cavity. So abscesses may be developed, especially if you have a ruptured appendix. You can develop abscesses because of the bacteria that has gotten into your peritoneal cavity. Can have either localized infection or this can actually spread into a systemic infection and cause sepsis. Treatment, surgical treatment. So basically remove the appendix and give antibiotics are pretty much the treatments for appendicitis. Complicated appendicitis, you might have some drains. If you have an abscess, then you might have a drain to remove the abscess. But in basic appendicitis, you're just going to remove the appendix. And there's your diagram that you guys can refer to in the book. Signs and symptoms: periumbilical pain related to inflammation, nausea, and vomiting is also very common. A very common symptom is localized pain in the right lower quadrant. You can actually have tendinous rebound, which means that when you press on that appendix or that right lower quadrant and you release it, and then they complain of pain, that is rebound tenderness, so that is another sign of appendicitis. If the appendix ruptures, they can have temporarily relief from pain, which is not a great sign because you don't want that appendix to rupture. Also, low-grade fever, leukocytosis is a very common symptom. Tachycardia, hypertension. If you do have if there's a systemic infection created by appendicitis, you can have low blood pressure because of the toxins that are leaking into the peritoneal wall and possibly leaking into your blood system. Diverticulitis or diverticular disease is, we have a couple different ones: diverticulum, diverticulosis, or diverticulitis. So a diverticulum is an outpouching, I can't say that word today, outpouching, a herniation of the mucosa. So another pouch. So basically a herniation is just as a pouch coming from whatever mucosa or epithelial layer that is being affected. Diverticulosis is asymptomatic diverticular disease, but you can have acute diverticulosis or diverticulitis is when that diverticula becomes inflamed and that causes a lot of pain. Diverticular disease. So in diverticulum, you have a weakness between the muscle layers, a bulge appears, pressure increases. It may be asymptomatic. It may cause inflammation of that area. Cramping, tenderness, nausea, and vomiting are symptoms. A slightly elevated fever or slightly elevated temperature, and a high white blood cell count are also symptoms. Treatment includes antibiotics and dietary modifications to prevent the stasis. Also, they will tell you not to eat nuts or seeds that can get caught easily in those pouches. Going on to colorectal cancer. Most of them are from polyps, happen because you have polyps. Early diagnosis is essential. That's why you do get colonoscopies or some kind of surveillance after the age of 50, because most of the time the cancer occurs after the age of 50. However, if you've noticed recently that there are more diagnoses of colorectal cancer in younger people in their 40s. So it is actually changing who is getting diagnosed, and it is happening to younger people. So that's something to look at. It could be diet related, could be something that we can modify to help reduce those risk factors. Risk factors do include multiple polypsis or familial multiple polypsis, meaning that it's a family kind of genetic that you have polyps, ulcerative colitis, and other factors, genetic factors, environmental factors, which include diets low in fiber. Initial signs depend on where the cancer is occurring. Changes in bowel sounds, alternating diarrhea and constipation, bleeding, fatigue, weight loss, anemia. Those are all symptoms of colorectal cancer. Treatment would include surgical removal, radiation, and or chemotherapy, a combination of one or all three of those to treat the cancer. Common signs and symptoms of colorectal cancer. So depending on where it's located, is you can see if it's lower in the system, in the rectum, you can see solid stool, but you can see also ribbon or pellet stool, incomplete emptying, red blood on surface of stools, and the descending colon, it's constipation, abdominal fullness or distension, also blood in the stools. Ascending colon, you'll see liquid stool because it happens higher up in the colon. Then as it comes down here, it becomes more solidified. Transverse colon, semi-solid stool if you have a cancer in this area. Intestinal obstruction is the lack of movement of intestinal contents through the intestines. More common in the small intestines. You can have mechanical or functional obstructions, depending on what's causing the obstruction. So mechanical obstructions can include tumors, adhesions, or hernias. Functional obstructions can include spinal cord injuries, paralytic ileus, because of surgery or caused by toxins or electrolyte imbalances. So when you do have an intestinal obstruction, you have a accumulation of gases and fluids before that blockage, and that can distend the intestine, and that can stimulate the intestine to have stronger contractions to try to move those contents along. Then you can get more secretions in the intestines, which will then in turn compress the veins in the wall, and the intestinal wall becomes very swollen, and the swelling of the intestinal wall will prevent any kind of absorption or decrease the absorption of the nutrients. So also this can lead to persistent vomiting because you can't pass through that obstruction. So what happens is it just comes back up because it can't go down, it comes up. And this can cause additional loss of fluids and electrolytes because now you're vomiting, and you can result in hypovolemia. So if the obstruction is not removed or it's not corrected, then you can have some gangrenous tissue, some necrotic tissue that becomes infected, and that can also lead to decreased innervation, complete cessation of peristalsis, and the paralytic ileus can occur or begin. So functional obstructions or pelvic ileus can occur from abdominal surgery, spinal shock, inflammation with ischemia, pancreatitis, peritonitis, infection of the abdominal cavity, hypokalemia can cause functional obstructions. A mesenteric thrombosis can cause an obstruction, and toxemia can cause obstructions. Mechanical obstructions can, most common mechanical obstructions are caused by adhesions. A lot of times if you had previous abdominal surgery, that scar tissue will create adhesions and that they can twist or constrict the intestines. Hernias can also cause obstructions. Scar tissue, I said masses or tumors. Intussusception, which is when the abdominal, the intestines kind of move in and out of each other. That's more common in pediatrics when they're about 2 to 3 years old. You can have a volvulus. Hirschsprung's disease is also something that is a pediatric disease that they usually diagnose in pediatrics. Can cause intestinal obstructions, and also later on in life, once it's been corrected, Hirschsprung's disease can create intestinal obstructions or be a risk factor for intestinal obstructions. And also chronic obstruction is related to chronic inflammatory conditions. Because of the risk of perforation, of infection, of sepsis, obstruction of the small intestine is considered a medical emergency and needs to be dealt with very quickly, which usually means surgery and a resection of that small intestine and possibly a diversion of an ileostomy or an ostomy. Obstructions of the large intestines are not quite the same emergency as the small intestine. Usually develops over time, as characterized by constipation and maybe some mild abdominal pain, some anorexia, vomiting. You treat the underlying causes, replace fluid and electrolytes, and sometimes surgery and antibiotic treatment is necessary. All right, moving on. Here's a nice little graph that you can look at in your book that kind of shows you some more effects of intestinal obstruction and how it creates disease. Peritonitis, again, it is inflammation of the peritoneal membranes, causes from enzymes released by pancreatitis, urine leaking from a ruptured bladder, chyme that it has been spilled from the perforated ulcer, bile escaping a ruptured gallbladder, can be caused by blood or any other foreign material in the cavity. So peritonitis is usually a secondary complication of a primary disease, to keep that in mind. Bacterial peritonitis can be caused by direct trauma affecting the intestines, so a ruptured appendix, abdominal surgery. You can get peritonitis from abdominal surgery if there's some bacteria or object or foreign material is left over or an infection develops. This can cause pelvic inflammatory disease in women when the infection reaches the fallopian tubes. Signs and symptoms of peritonitis is usually sudden and severe, generalized abdominal pain, very local tenderness. Vomiting is very common, abdominal distension is common, dehydration, hypovolemia, low blood pressure, tachycardia, fever, leukocytosis are all signs and symptoms of peritonitis, but most likely you'll have the tenderness and the abdominal distension is going to clue you into what that problem is. Treatment depends on what the cause is. Like I said before, the peritonitis is usually a complication of a primary disease, but you might need surgery, you might need a paracentesis. Usually you are given antibiotic therapy specific to the organism that they can culture and that is causing the problem. So here's a nice little graph of peritonitis, and you can again, I think, refer to this in your book. And that brings us to the end of this lecture. So I hope you guys took some breaks and didn't do this all at once. But email me or text or send me a message through Canvas if there's some of this content that you want more information on or need help with. All right, have a good day.